know or want to know, or if you have questions while we're talking, please just let me know. All right, these are things you already know, and I put it down here for future reference because in case you want a reference for the things that I'm telling you, you already have them. See, I've got the things up there. Okay. And what is patient blood management? The way this started was back in the 80s. People started realizing that when their patients got more blood or less blood, it didn't help them to have more blood. And I'll show you the first trial on that. But it's all based on evidence. We don't ever try to tell the medical community, the staff, what they should order, what they shouldn't order. We give guidelines and we ask for indications so that we can evaluate how well we're doing. The other thing is to avoid waste. This is a huge part of my role and something I take extremely seriously because somebody has sat in a chair and donated that blood, and it's a scarce and precious resource, and wasting it is, to my mind, a really bad thing to do. So the way you, it's okay, it's all right. I like to start early so I can get as much in as possible. I haven't said anything on that important yet. So the way you can avoid waste is to be ready for your patient to be transfused before you go down and get the blood. And that means you've already taken vital signs, you've assessed them, they're there in the room, and haven't been taken away for a test, that sort of thing. Check your orders and make sure you know exactly what your patient needs and why they need it. And the safety is evaluating the risks and benefits. So this is the first trial, 1999, that actually put down random controlled trial to show that in black and white that patients do not do worse if they have a lower hemoglobin. So that was the revelation. It was based on the history of the Jehovah's Witness use in surgery when they refused blood products and did just fine for the most part. That's what started people looking into why they don't need more. And this is just a little background information about stewardship and conservation of blood products. The point of this is that the donor pool is shrinking, but the use of products hasn't shrunk very much, although we're working on it constantly. So that's why, as a community resource, we want to make sure we're good stewards. So I'm talking about risks and benefits. What are they? Shortly after the HIV epidemic, people were very concerned about getting blood products if they didn't want the virus transmitted, obviously. So that was seen as not too important, the transmissible diseases. But they saw a lot of reasons to give blood products, and they thought that all these things were the reasons. But now we look at it and we say, we have to weigh the fact that patients do have adverse events and adverse effects that may not be seen right away, but it stays with the patient forever. And why is this? Because all these things in the blood have foreign antigens on them, and even if you don't have an overt adverse event, you have an antigen-antibody response that stays with you forever. So the more blood you get, either in one time or throughout your life, it affects your ability to respond to immunological threats from then on. This is just a little picture of red blood cells, mostly just for your future reference. I'm sure you all know why we need red blood cells carrying oxygen from your lungs to your cells. And this is a picture, I just love this picture. I've got a huge one on my wall So I thought I'd share a little bit of it with you. So you can just get an idea. If you've already seen this, don't worry. It's just there in your book. Plasma is really one of the most antigenic properties of whole blood, and because that's where a lot of the immunoglobulins and various proteins, all kinds of things live, and they keep your body in sync with how much blood is in your tissues versus in your bloodstream. That's how you get edema if you have too many proteins and it starts pulling water out of your tissue or into your tissues from the blood. And platelets, this just shows a cute picture of what they look like ordinarily, and once they're activated, then they clump together and they plug up holes, and they also promote clot forming activities. They try to prevent leakage, and the thing that you might be concerned about is whether your patient has had aspirin or a Plavix-like drug. So these are important because they block the effect of platelets. So you need to know whether to be concerned or not about the bleeding prospects of your patient. And just in case you want to know where cryoprecipitate comes from, it's a matter of production from the fresh frozen plasma that's thawed, spun down, precipitated off. So it's a little process. But the one thing that I would like for you to be aware of is that once cryoprecipitate is thawed, it's only good for 4 hours. So make sure you're ready to give it. When you call the blood bank and ask them to thaw it, if you think that it could be more than 4 hours, just wait. So the risks again are that it's a foreign thing, and it's really a liquid transplant in that you have the foreign antigens, and you can have some of the similar effects such as graft versus host disease. It might not happen after the first transfusion. You might have to have another transfusion to have the effect of it, but it's going to last throughout your life, and you can have severe consequences that could be immediate or delayed. In case you thought that wasn't such a risky thing, the things in red are the adverse events that can happen. I'll tell you a little bit about those things, but it's really a much bigger topic than what we're going to go through today. But if you were worried about HIV, you can see that this is much more common. If you're worried about death from anesthesia and medical errors, hospital infections even, this is riskier. So what is the nursing role? You are obligated to do a head-to-toe assessment. Before you give blood products, during and after. It doesn't have to be like in nursing school when you write down every single little thing. But look at your patient and mentally check off, do they look diaphoretic? Do they look normal? Do they look like they're having a hard time breathing? What is their blood pressure? Or their heart sounds normal? And then you can evaluate from before the transfusion to during to after. But if you're not aware of these things, then you won't know if there's a change. And understanding why your patient is getting a transfusion is very important, because you need to make sure that they understand why they're getting a transfusion. If you don't know why the patient's getting a transfusion, not only will you not be able to help your patient understand it, but you won't know what to look for to see if you have improvement. So you need to be able to give that feedback that the patient responded, that the symptoms that you're treating have improved. And I'm going to tell you something about informed consent in just a few minutes. Okay, I'm big on risk because that's, transfusion safety. So these are the things that can go wrong. And these are the things that you can do so that they won't go wrong. Pre-transfusion testing is not only what happens in the blood bank, it's how you label the tube that goes to the blood bank. I don't know how many of you have used Typenex fans. Are y'all from here? Have you used them before? No? Okay. So I'll show you a picture of it in a minute. It's a little tiny bit complicated, but it's not hard. But if you don't know what it is, when you go to either draw blood for cross-match, or if you need to take the blood that you get and put it and match it to the blood that you've got hanging to make sure it's the right product for your patient, you need to understand about the Typenex. The medical decision to transfusion is right up there at the top. It's not that we can say to a doctor you can't transfuse, but just being aware that you might recommend that your patient is doing fine or they're not doing fine, and not just base it on lab numbers. The issue and transport part, in the blood bank, they've seen a lot of very strange things happening lately, and we've just got together a DOL to show everybody what the problems are with transporting blood products in the hospital. It sounds like an easy thing, but people will come down. They won't have any paperwork saying who the blood is for, how much they need, much less their hospital ID or their blood bank ID. So this cannot happen because the blood bank doesn't know. So if you say, I have to pick up the blood on Mr. White, they don't know what that is. That's one thing. So positive patient identification is your number one factor. So you go to the blood bank window and you have your information, and then you read it with the person issuing it. Have you all read for blood product identification and given blood products? If you haven't, just think about this. The wrong product can kill your patient. So you have to take it seriously. So when you stand in the window and they're reading off the numbers to you and you're reading off what you have, you've got to pay attention, because what if they're wrong? People make mistakes. That's why we have redundancy, so that even if somebody else makes a mistake and the second person makes a mistake, hopefully by the third person's check, it'll be correct. So at the bedside, the reason it says bedside identification is that you don't do it at the nurse's station. Never, ever. You take your product by the patient's bedside and compare it with their armband, not just a piece of paper that you've got, the orders or whatever that you're comparing it to. Because I've seen it happen that the wrong blood was given because they had a sheet of labels, patient labels, but they didn't go to the armband. So you have to do the armband, you have to do it at the bedside. And then you're monitoring and evaluating the way we talked about. And if all of those things line up and go properly, you'll have a successful transfusion, unless you have a bad outcome. Okay, this is for future reference. Don't try to read this. I want you to know that mistransfusion is always a human error. That's the way it happens. It's called an acute hemolytic reaction, because what happens is the blood cells that don't match destroy each other. So if you don't have any red blood cells, you're going to die. And it happens fairly quickly. So I'm trying to put the fear of God into you. Just take a minute, do it slowly, and look at it. So some of these names you may or may not have heard of. Taco has to do with overload, tissue overload. It's transfusion-associated circulatory overload, abbreviated TACO because it's easy to remember. But circulatory overload is one of those things you're going to be looking for before, during, and after your transfusions. So if your breath sounds are already a little wheezy or a little wet, you know that putting a lot of fluid into the patient is not going to be helpful if you do it really fast. And that's the main reason that people have this reaction, is because the transfusion is going in too fast. You've got 4 hours. If need be, you can ask the blood bank to separate your unit into two. If your patient's in bad shape, ask your doctor for an order for Lasix or whatever. And the trolley is a very serious problem. It's associated lung injury. And what happens is, they're pretty sure, the proteins in the blood cause an inflammatory response, and it's like ARDS. It's very hard to control, and it's very hard to reverse. But it can be done if you're very alert and get your patient on a ventilator right away. It can be managed. So these are things you should already know, but there's a list for future reference. And we talked about the patient's disease or condition. If your patient has a coagulopathy, then that might be the reason they're getting platelets. If they're going to surgery and they've been taking Plavix or aspirin, that could be a reason. Red blood cells, obviously, if their hemoglobin is low. But we found, and the guidelines will show, that a patient can have as little as 7 grams of hemoglobin and not suffer any ill effects. Now that's if they're not bleeding and they're not symptomatic, but just maybe short of breath. A little tachycardia is okay, go ahead and treat them. Now, if they have coronary artery disease, that puts a little more stress on the heart, obviously, and hemoglobin of 8 is acceptable for that. So if you're aware of these things and you see your patient has a hemoglobin of 10 or 12, maybe there's an error in the orders, or maybe there's another reason that you don't know of it. Maybe you should find out what it is, because that's not a normal order. So if there's something else going on, you need to know about it. Positive patient identification. Oh, Typinix. I think I've got another slide on Typinix. So this is what's coming out that you'll be required to take is transported training. And what it says, in a nutshell, it's like so short, it'll take you 10 minutes. But it's a mandate that we have to have it checked off, because if any regulatory agency comes over and they follow through people that are getting blood transfusions from the blood bank to the patient's bedside, and this happens, they will want to know if the person that picked up the blood had transport training. So we have to have that on file. The main considerations is you pay attention, you don't dawdle, you don't go get a Coke on the way back, and I promise you these things have been done. I don't think any of you would do it. But just so you'll know, that you have to take it very seriously, and when you take it, you have to give it to somebody. You cannot put it on a desk. You can't put a cooler on the floor. You have to hand it to somebody who's responsible for that transfusion. Time considerations, you know, you've probably heard the 30-minute rule. Well, that is an estimate that if your blood products are out over 30 minutes, they're going to get too warm, and you won't be able to bring them back, because then they could put them back in the refrigerator. So you're going from cold to warm, warm to cold. See what I'm saying? That breaks the red cells and makes it not effective for the next person that gets it. But if it's been, pretty close. They can take the temperature of the bag. It's not foolproof, but if the temperature is below the necessary level, they may be able to return it into the circulation. So that's the whole reason why you don't want to bring products back unless you are in that 30-minute window. And if you're giving the product, obviously you've got 4 hours to safely infuse the product into the patient, starting with when you pick it up. Because once it comes out of the refrigerator, that's the amount of time that needs to be concerned with. As soon as this gets to be posted and everything, you will not be able to pick up blood products without taking it. The blood bank person that is checking out the blood with you will ask you, did you take transporter training? And you can say yes or no. If you haven't, you need to call somebody else. And we're going to make this really obvious. We're going to have a lot of education on it. And it's just that you need to be aware that you have to take it. Because nobody else can really follow up on it for you. When it's assigned to you, do it. I promise it is so short. Just be on record. So we've kind of gone through this. These are the guidelines I told you about. They're built into the order sheet. But I just wanted you to be aware of what there is. You don't have to know all those things. You just have to look at the order sheet and tell you what to do. Your responsibility is to make sure that there's a date and time and a patient label on the order that you bring down, and that it's marked with how many units are needed, what they are, and there's little check marks for indication. That's all you have to check. But you have to make sure it's signed, either as a telephone order or by the physician, and it needs to be legible. The other thing that you need to write on there is the number from the Type-X. Oh, that promised Type-X. Here it is. This is the picture. So what you do is, when you check your patient's identification with their armband, you pull off a label. Real simple. And you put it, you peel up that, probably should have that right. Peel up the plastic. This pulls up like a Band-Aid, and you take that patient chart label and just put it on there, and then you put the plastic back over that. That's how that goes on. Before you tape it over, though, you're supposed to put your initials, your lab code number. If you don't already have one, you will get one, because everybody has to have one. And the date and time. And you cover it up. That little bracelet part that goes around, that's the labels that have the Type-X number on them. And that, one of those labels has to go on to either the tube you're sending, or they have to, that number has to be on your order set, so that the person that's checking in and checking out your blood can compare it. They have to match. And then you'll be checking your blood bag, and that's what the order sheet looks like. You know, obviously you can't read all that, but it's just, that's what it looks like. It's very simple to mark, sign and date. And here's the blood label. So I've marked 5 things to look at, because this is how you'll read at the window with the blood bank, and this is how you'll read when you take it to the patient's bedside. You always have to have a witness. You have to have 2 people checking it. At some point, we will have barcoding at the patient's bedside, and once you have that, that acts as your second person. So all you have to do is barcode it. But for now, you will read the unique donor identification number. That, it always starts with the W. I don't know why, it just always does. And that's the W number. You'll know that refers to the blood itself. That's the donor number. The number of the patient or the person that donated that blood. So it's tracked from the time of donation to the time of preparation at the donor center, sent to us. The blood bank has that on file in their system, and then that's how you know who it came from, where it came from. The reason you have to know this is manyfold, but one of the reasons is that if you have a transfusion reaction, that's the number you'll want to compare with what you were supposedly getting in the blood bank. If it's not the same, then you know there's been a big problem. Otherwise, say you get a temperature elevation. That can happen a lot of times, but it can also be the precursor to several other reactions, especially septic reactions to the bacterial contamination that can be present, especially in platelets. So what they do is they take that donor number and they trace it back to the person that gave it. They redraw their blood. They check the blood, that there's little segments in the blood bank. They do cultures. They have to notify the donor's physician, the donor center, and the FDA. So it's an important number. The other thing is what is in the bag. That's red blood cells, but it also can give you other information about whether or not it is drawn into saline or whatever. The special testing information is something that you will be interested in, because if your patient needs irradiated or CMV negative, something like that, that's how you'll know whether you got the right product. And the expiration date, it's something that can actually happen that your patient will get an expired unit. It's not often, but we always check that. That's one more thing to check in the blood bank when you're checking the blood and when you're handing the blood. And then, of course, the type. Okay, now I want to tell you about informed consent. Did y'all understand about type and X? Was that enough information? Do you have any questions about type and X? Tell me. All right, you're all responsible for knowing anything. An informed consent is not the same as a consent form. We have a new consent form that's going to be attached with the transfusion order set. So when you pull that up to print it out, you'll have the transfusion consent form. It's different from the one we have been using, because that was just about this big, and this is a whole page. And it lists the risks, benefits, alternatives, and the right to refuse, and it says, I understand. So that's the important part, and you need to discuss this with your patient. It's not your obligation to explain it. That's the doctor's responsibility. He can ask somebody else to do it for him, but ultimately it's on him. So if he's going to trust you to do that consent form, and something happens to the patient, it's going to be the doctor's fault, not yours. So ask the patient, did you understand? Do you have any questions? And if they say no, that's great. But if they ask questions and you feel like they really don't understand, you should call the physician and let him know somebody needs to come talk to them because they didn't really get it. And why is that important? It's an invasive procedure, and it has high risk, low probability. There's some things that are low risk, high probability. This is the opposite. It doesn't happen often, but when it does, it can be a huge problem. And if your patient doesn't understand that and they have a bad reaction, they can say, I didn't know that could happen. Well, there it is in black and white, and it's spelled out what can happen, what will happen if you don't get a transfusion, what are the alternatives, and why you need it. So it's there for your benefit, the patient's benefit, and the doctor's benefit to have all that spelled out, and so there's no misunderstanding about, I didn't expect to have this reaction. And these are some references to, why the doctor has to sign it, why you need it. And here's my summary. Oh, I did much better this time. This is what we said we were going to talk about in the beginning. So we talked about blood products individually, what's in the whole blood, that we have red cells, platelets. I didn't tell you anything about white cells, and the reason I didn't, even though they're on our cell chart, is coming from the bone marrow. That's where the stem cells are made. Because we don't give white cells. White cells are extremely antigenic, and whereas in the past they felt that it might help people with a low white count, like after chemo, to get white cells, they quickly found out this was not a good idea, so I didn't go into that. The plasma is used for coagulation problems. Patients can have factors that are missing in their blood, like hemophilia, on Willebrand syndrome. I mean, there's quite a few factors, but it really doesn't need to be used as often as people would like to use them. We discourage it because it doesn't last long, it's not specific, and it's very antigenic. Blood consent and signs and symptoms. Okay, so what do we do if you think your patient has an unusual sign or symptom? What's the first thing you do? Thank you. Okay, I think that's been drilled into everybody's head for a very important reason, because every minute that it keeps dripping in there is multiplying your chances of continuing and worsening of your symptomatology. So don't wait and call the doctor first. Stop it, run some saline in there so it won't clot off. Call the blood bank and let them know. What happens in the blood bank is they start doing their clerical check right away. They're going to go through and make sure that they tested that product, they'll test it again, that they gave you the right product and dispense the right product. On your side, you're going to look at the patient's armband and bag again, just to make sure there wasn't a mistake. And then you're going to draw a sample of blood and send it to the blood bank so they can check the patient's blood to see what's going on. The main thing they're looking for is hemolysis. And the hemolysis comes out by having an antigen-antibody response on the red cells that lyse them. So that's hemolysis. And then they can go from there. If the bag is cloudy or bubbly looking, you will not be giving it, because you'll notice that. But bacteria takes some time to grow. You know, it can be a day later and you put those bacteria in your patient and they can start growing rapidly. It doesn't take long for it to grow rapidly. So you have to monitor your patient not just before, during, and after, but, you know, peek in on them later in the day and in the morning and make sure they're still doing fine. And realize that a transfusion reaction can occur at any point in time, not just during the transfusion. It can happen later. I've seen it happen to outpatients that get their blood products and they're released to go home because they've been there for a long time. And they're released with instructions that say, if you have this, this, and this, call us immediately. And had a person that started spiking a fever, came back, and they were septic. Now, I can't tell you it was from the transfusion because I wasn't there, but it very could have been. It may well have been. So that's why you have to pay attention, not just during, but after as well. Anything about transfusion reactions that you want me to tell you?
Do you use the topical prevention weight-based guideline, the 1 to 2 mils per kilogram per hour here?
For rate, it's only a suggestion.
It's not required.
No, because, and this is why, the AABB guidelines, and that's the American Association of Blood Banks, but they don't use that term anymore, it's just AABB, does not establish an exact guideline because you need to use your nursing judgment. So if your patient, like we talked about, already is in fluid challenge status, you're not going to run it in that fast. You're going to run it in much lower. And I'm sure all of you start slow, check after 15 minutes, and then speed it up if they're not having any problems. But just to that certain point. The only time you run in blood products really fast is if the patient is going to be crashing.
I know that where we're currently, there's a lot of focus on the topical prevention, and it's the 1 to 2 mils per kilogram. But if you have someone who's, let's say, I had a 900-pound patient, and they had EF of 10%, and they were on dialysis. When you actually calculated it out, the rate was transfusion like 90 minutes. And so I was like, how is that actually going to prevent topical if you're, you know what I mean?
Well, in dialysis, it's a little bit different because they're taking off fluid as well as putting fluids in. So that's why that. If a person that has a really low blood pressure and they're bleeding, then of course you can them faster. Okay? Okay, I just about took up my time. I really would like if you ask some questions, if you have any suggestions for me as to what you'd like to hear about that I haven't spoken about. Was this helpful? Good. I'm going to take that as a yes. And I appreciate your attention. I have cards if anybody wants to take one so that if you really had a question that you didn't want to ask me today, you could ask me anytime. Very accessible. And I would love to hear from you.
Thank you, Ms. Robin.
You're welcome. Thank you for having me.
We love it.